Ready to begin?
Yes, so I'll do the introduction. Yep.
All set.
Well, good evening, everyone. I'm Dr. Judith Lin, Professor and Chief of Vascular Surgery from Michigan State University College of Human Medicine, Chair of Cardiothoracic and Vascular Surgery at McLaren Greater Lansing. As we promote Venous Disease Awareness Month, I would like to welcome you to this Midwestern Vascular Surgical Society webinar on management of complex venous disease. Also, I would like to thank Cook Medical as the sponsor of our MVSS webinar tonight. Before we introduce the speakers, please note the Q&A button at the bottom of your screen. To submit your question to our presenter, click on the button and open the Q&A window, type your question, then click on the submit button. The moderators and other attendees will see your questions, and the moderator will select questions that will be answered by our presenters. The Q&A segment of tonight's webinar will occur at the conclusion of the fourth presentation, but we encourage you to submit your question at any time during the presentation. And tonight, I have the distinct honor to co-moderate this session with Dr. Carlos Bechara, who is a professor of surgery at Loyola University School of Medicine, Program Director of Loyola Vascular Surgery Fellowship, and the co-director of the Loyola Center for Aortic Disease. This MVSS webinar is focused on recent technology for managing complex venous disease as presented by vascular surgeons, and we are joined today by 4 distinguished speakers with a variety of expertise in using these new technologies. Our first speaker, Dr. Hui-Ti Chen, is a vascular surgeon and assistant professor of surgery at Michigan State University College of Human Medicine in East Lansing, Michigan. She obtained her medical degree from Baylor College of Medicine and is a board-certified vascular surgeon, having completed her vascular training at the University of Michigan. She then practiced for several years in Virginia before returning to Michigan at Henry Ford Jackson Hospital. And her interests include medical education and curriculum development. And as an attending vascular surgeon at McLaren Greater Lansing, she continues to dedicate her time both in and out of the OR to medical students and resident teaching. So Dr. Chen will discuss current guidelines in venous disease.
Thank you, Dr. Lin, for the warm introduction. Thank you also, Dr. Bechara, the Midwestern Vascular Society, and Cook for the opportunity to speak on this topic. Let me go ahead and share screen then. So this topic is current guidelines of venous disease. This is just the facts, ma'am. No exciting images from the operating room, but I do see some that are coming up on upcoming talks. I have no disclosures. So the focus of this particular set of guidelines is I'm going to be talking about the SVS, AVF, and AVLS clinical practice guidelines for the management of varicose veins of the lower extremities. So as we all know, the previous guidelines came out in 2011 from the Society for Vascular Surgery and American Venous Forum clinical practice guidelines. So now, since that publication in 2011, there is now 5 to 10-year follow-up data from multiple prospective randomized controlled trials, and these were incorporated in the updated guidelines. So far, what's been published as of 2022 is part 1 of the guidelines, and that is regarding duplex scanning and treatment of superficial truncal reflux. So I would expect that more parts are forthcoming and to keep an eye out for those. But right now we just have part 1, and that'll be the focus of today's discussion. So there's multiple points of discussion for the guidelines for part 1, and I'll go through each one of them. There's 5. So the first is the use of duplex ultrasound in the diagnostic capabilities in C2 to 6 disease in adults. The second is the surgical approach, high ligation and surgical stripping versus endovenous ablation for great or small saphenous vein incompetence. The third is thermal versus non-thermal ablation techniques for these patients with greater small saphenous incompetence. The fourth is regarding perforating veins, whether to ablate versus not ablate in these folks with C2 disease. And then finally, regarding treating the varicose tributaries, concomitant or staged after initial treatment with greater small saphenous vein reflux. So to break down each one of these, again, the first one is regarding the diagnostic evaluation of venous incompetence with duplex ultrasound. So you can see the first bullet point here was the recommendation back in 2011. So the recommendation was for these patients with chronic venous disease, in addition to a history and physical, the duplex scanning is a complement to that part of the patient history. And it basically says the test is safe and reliable. So in 2022, it's become a lot more specific. So it says that the societies recommend duplex scanning as the diagnostic test of choice to evaluate venous reflux. There are some additional points made in 2022, which I think are incredibly pointed and helpful. So the bolding is mine, but you can see that first bullet point where the recommendation is that duplex ultrasound be performed by an IAC or ACR accredited vascular laboratory by a credentialed ultrasonographer. And also you can see bullet point 2, which again, the bolding is mine, but the study should be interpreted by a physician trained in venous duplex ultrasound interpretation. There's also additional points made, such as number 3 there, where the description is that transverse grayscale images should be obtained with and without transducer compression. So you can see that the language with the new update is far more specific. One more point made in the new guidelines is regarding how the study should be performed. And you can see it includes diameter measurements of the patient with the leg independent position and how the diameter should be measured as well. So far more specific description of how the study should be performed. So that's regarding duplex ultrasound. Number 2 was regarding surgical versus ablation techniques. So high ligation and stripping versus any endovascular ablation technique for these patients with greater small saphenous incompetence. So the first bullet point, 2011, the recommendation was endothermal ablation is recommended due to decreased pain and morbidity over open surgery. So in 2022, again, the bolding is mine. The recommendation is to perform ligation stripping if the technology or expertise of ablation is not available. So that's a different way of phrasing it. It almost seems like you should really err towards performing ablation first, but they don't say it that way, but to recommend open treatment only if endovascular ablation is not available. Additionally, you can see the recommendation is endovenous ablation over high ligation and stripping of great saphenous vein, small saphenous vein because of less post-procedural pain, earlier return to regular activity. And also you can see the second bullet point also discusses quality of life and recurrence as well. So in those patients, laser ablation, radiofrequency ablation, or open surgery are all recommended over the ultrasound-guided foam sclerotherapy. The third guideline is regarding thermal versus non-thermal ablation. So back in 2011, again, some of the data that we know now had not come out yet. So the recommendation then was thermal ablations, whether it be laser or radiofrequency, are safe and effective, and the societies recommend them for treatment of saphenous incompetence. And again, referring back to open surgery, we recommend endothermos venous ablation over open surgery. That was back in 2011. So in 2022, the recommendation is now both thermal and non-thermal ablation for great and small saphenous veins. and a suggestion of either thermal or non-thermal ablation for anterior or posterior accessory saphenous veins. For guideline 4, this is regarding perforating veins. Back in 2011, the verbiage was, we recommend against selective treatment of incompetent perforating veins in patients with SEEP2 disease, and suggest treatment of these pathologic perforating veins with these specific parameters if they're involved with a healed or open venous ulcer. So that's quite a bit different from what we see now in the 2022 update. So in these patients with SEEP2 disease, the recommendation is we recommend against treatment of incompetent perforating veins and concomitant ablation of the superficial truncal veins. But in patients with recurrent symptoms after previous ablation, there is a suggestion of treatment of the perforating veins if it is the origin of these symptomatic varicose veins. So this doesn't have the same verbiage of there must be involvement of a active or healed ulcer. And then finally, guideline 5 is regarding whether to perform concomitant versus stage treatment of the varicose tributaries. In 2011, the recommendation was ambulatory phlebectomy for treatment of these veins, performed either during or at a later stage. And the specific description is if general anesthesia is involved, then to perform it concomitantly. Now in 2022, the recommendation is ablation of the refluxing venous trunk and concomitant phlebectomy or sclerotherapy of the veins for great saphenous or small saphenous vein. So quite a bit different from what we saw in 2011. Finally, for symptomatic reflux of the major superficial venous trunks, undergoing initial ablation alone. So if the option is just to go at it alone first, then that these patients need to be followed up for at least 3 months to reassess whether or not there's any need for a staged treatment of those varicosities. So in conclusion, the new guidelines draw from 11 years of updated literature. Looking specifically, it looks like they drew from, I think, eight or nine randomized controlled trials with 5-year data and 1 with 10-year data. So there's much more specific language now in the 2022 update. As I mentioned before, this is only part 1, and it's only regarding basically superficial truncal reflux and duplex ultrasound for diagnostic evaluation. There are additional topics from 2011 which aren't touched upon at all in this part 1. Additional imaging, lab evaluation, the way that the outcomes are assessed, and also pelvic varicose veins. Additionally, there's now input from the American Vein and Lymphatic Society, so I would expect that there would be some guidelines specifically detailing lymphatics as well for the additional parts to be published. So looking forward to seeing what those entail. Thank you very much.
Thank you, Dr. Chen. So next, we're going to have my partner, Dr. Salt. He's, he actually went to med school at Ohio State and East Virginia for general surgery, and then eventually made his way to Chicago for Northwestern for his fellowship, and he joined us, and he's an assistant professor at Loyola and associate program director and the director of the complex aortic program at Heinz VA. So he's going to be talking to us about venous stenting for iliofemoral deep venous thrombosis. Dr. Salt.
Thank you, Dr. Bachar and Dr. Lin. I appreciate the MVSS, the New Horizons webinar series, and Cook for the opportunity to talk this evening. So here are my disclosures. But more importantly, I do have to disclose that it was only a couple of months ago that Dr. Milner had me debate that stenting the left iliac vein is ridiculous against my opponent, the Honorable Dr. Muck in Cincinnati. However, he was too scared of me, so he had his fellow do it because he didn't want to join the debate. So as we know, post-thrombotic syndrome follows acute DVT. You get outflow obstruction, asymptomatic to phlegmasia. And so that sort of led to trying to figure out what to do with these patients. Ultimately, long-term, you get the post-thrombotic syndrome. It's edema, pain, heaviness, hyperpigmentation, lipodermatosclerosis, ulceration. But you can't diagnose that unless it's 6 months out after acute DVT, because there's a lot of similar overlap on symptoms. It occurs in about 1 of every 2 to 3, so half to a third of patients will get post-thrombotic syndrome after acute iliofemoral DVT, and a majority of the developed symptoms within 2 years of diagnosis of their acute DVT. Really, it kind of treatment has always hinged on this open vein hypothesis that if you alleviate the obstruction, alleviation of the obstruction will prevent impaired venous return, valvular damage, and reflux. So the sooner that you can get there, the less likely you're going to get those problems that lead to post-thrombotic syndrome, and really push for some open versus endo options. So in reality, with all of that, we had the CAVENT trial, which was published in 2011. It was looking at open venous thrombectomy versus catheter-directed alteplase. And what they suggested was that there was an overall decrease in post-thrombotic syndrome of about 28%. However, in this cohort, only 34% were iliofemoral DVTs, and they only stented 17%, which was 15 patients in the whole group. This sort of pushed to the biggest trial when we talk about DVT management, and sort of was the ATTRACT trial, which was pharmacomechanical thrombectomy versus anticoagulation. And sort of overall, what they found was there was no difference in post-thrombotic syndrome at 24 months, but they did see a decrease when they did some subset analysis of PTS in the obstructive iliofemoral DVT group. However, again, there was a very low rate of stenting in this patient population, with only 28% of patients getting stents. More recently, the CAVA trial used acoustic pulse thrombolysis versus anticoagulation. Again, just like ATTRACT, they found no difference in post-thrombotic syndrome at 12 months. But their stent rate went up, but it still was only about 45%. Again, not with a lot of subgroup analysis to really tell us what to do in this iliofemoral area. And really, ATTRACT is the big one that's kind of pushed most of us to be more aggressive in acute DVTs, to at least try to open it up. But the question is what to do about stenting. So again, really low stent rates in all 3 of these big trials, but they all had flawed methodology. They weren't great at randomizing. They didn't have great, initially we didn't have great descriptors. We had the CEP classification, but the Velada scores kind of come out. So as the vascular comorbidity, or the VCSS score has also come out, and that's allowed us to evaluate our literature a little bit better and have more uniform conversation about what the outcomes are. And realistically, we had pretty low rates of stenting, and the question is why. So iliac vein stents, really for the longest time, it was just the Boston Scientific wall stent. It wasn't a designated venous stent, but since about a few years ago, we've started actually having dedicated stents. We had the Bard Venovo stent, the Cook Venous stent, and the Medtronic Abre are all the ones that are currently on the market. There was a Boston Scientific Vici stent that was on the market, but has been recalled, and they have abandoned that stent. And it comes back to kind of going back to that same 2011 guidelines from the SVS and the American Venous Forums. They recommended stenting of the iliofemoral lesions in DVT with 1C evidence. So it's kind of interesting that all of those studies that sort of were done, especially afterwards, never really looked at that and didn't address what was going on with iliofemoral lesions in DVT. So my approach, whether it's acute or chronic, is to address this with the patient being in the supine position. So I know a lot of people will do prone positioning for acute DVTs when they're going to do the mechanical thrombolysis or pharmacomechanical thrombolysis, but I tend to access the popliteal or the posterior tibial vein in a supine position, because I think it just gives me more options as I go down the road. You want to leave access long enough to provide inflow. Chronic, I usually stay higher in the thigh, but not always in the common femoral vein. I might go down to the femoral vein. You want to cross the lesion. I tend to put a wire up into the IJ for stability, depending on what I need to do to use my IVUS, whether I need to balloon, stent, thrombectomy, or whatever adjunct procedures to give me more stability and kind of give me a better platform for doing a lot of my interventions. IVUS is really important in all of these cases when you're trying to address this. Single view angiography, we know, has about a 45% sensitivity. So it's really hard to just take a picture in a 2D image and determine whether there's stenosis. I think these cases really need IVUS. And most of the literature was designed with the idea that there needs to be a greater than 50% degree area reduction to warrant what we would call a significant stenosis, which is obviously lower than what we use in the arterial literature. But through all of the research that I've kind of did trying to find out where that came from, there's no clear cut answer. I think that number was sort of picked arbitrarily so we could have a cut point, and sort of started on the arterial side, but there's not a clear definition as to why 50% is what was used in all of these trials. So kind of giving you a case to sort of how I approach these things. I got a 57-year-old female, history of chronic DVT in the left external iliac vein, left lower extremity swelling, non-healing anterior shin wound, has tried compression, had a history of an IVC filter, which was removed 3 years prior, and her duplex showed chronic non-occlusive thrombus in the external iliac vein. So as you can see here, we've accessed the lesion from below. You can see there's a lot of collateral. So you know there's this venous hypertension that's sort of preventing your outflow, and that's why it's trying to go through the collateral flow. Here we have our IVUS of both the right and the left leg. And as you can see, coming down on the one on the right, everything's sort of open. There's a little bit of compression after the bifurcation, but on the left side, there's quite a bit of compression right there past the bifurcation, which is really leading to this hypertension and ultimately her wound on the other side. So I was able to cross the lesion. You can see on the image on the left, that's my IVUS catheter. I use that a lot for sizing, both the IVC, my iliacs, and to get length measurements. I did a kissing iliac vein stents here in the double barrel technique, which there is not a great answer as to whether you should do that or not. But based on where the lesion was for me, that lesion was right at the iliac confluence. So I felt that it was necessary to go higher. Given that they were thrombotic, I didn't want to increase the risk of thrombotic complications on the other side. The literature is not great on that answer. When you look at it, the ranges from about 3 to 10% of contralateral leg thrombotic events after unilateral iliac vein stenting into the IVC. However, a lot of it is underreported. So it's not entirely clear as to what the right answer is. And that's certainly debated as to whether you should do unilateral or bilateral stenting when you have very close to the confluence iliac vein lesions. Here I extended on the other side, and then this is the completion venography showing much better flow. You don't see that the flow on this completion through through a lot of those collaterals or the internal iliac vein. At 6 months, she had resolution of the wound, and stents were patent by duplex. You can certainly ask about what my routine is after this, but I know we're going to do a talk on what the current management is of treatment afterwards. Realistically, it's important to realize that, even though that these stents are great and you do get better pictures and you get better patency and you get better resolution of symptoms, the reality was in 2007, we had about a 67% primary patency rate with a 93% secondary patency rate. So while the primary patency rates aren't great, they do get better with time or with assistance, and it's actually a pretty low morbid procedure to keep open. And that's important to realize because obviously a lot of these patients that we're talking about putting these in, especially in acute DVTs, are relatively young patients. And so it's kind of interesting that this, we don't have a ton of great data to multiple years out, especially with these dedicated venous stents. So it's something we have to keep a close eye on because we don't want to be doing something that's going to create a problem. Sort of moving more to real world data that we have now. In 2020, there was a Swiss venous stent registry. They had 379 patients. Of those patients, that's a registry of all patients, all comers, whether that's for non-invasive lesions or nival lesions, so non-obstructive iliac vein lesions, or for DVTs and post-thrombotic. It was very nice that they separated this out so we can kind of really get a better breakdown. A lot of the literature shows that stenting for post-thrombotic syndrome, sort of the cat's out of the bag at that point. And while they do get some better resolution of symptoms, they tend to have lower patency rates. And you can see that both in primary and secondary patency out to 3 years. What's better is if you go after the acute DVTs, that's the blue line underneath, you'll see that you have an 80% 3-year primary patency rate, but a 95 to almost 96% secondary patency rate. So if you can get in there early, you can really keep these stents open and you have better outcomes than waiting for the patient to develop post-thrombotic syndrome and sort of attacking it at that point. But you have to be leery. 3% of patients will have migration. It's something we have to be thoughtful of. It's a devastating consequence or a complication to this procedure. And obviously it costs Boston Scientific an entire line of stents that is no longer on the market. We don't want to end up like the IVC filters and walking around the hospital late night having lots of different advertisements for, have you had an iliac vein stent? Please call us. We were going to do our class action lawsuits, and we don't want to be there. So we have to be very thoughtful. And I think patient selection is the most important part of this. So in conclusion, keep in mind that in acute DVTs, a third to a half of those patients with venous outflow obstruction will get post-thrombotic syndrome. While reintervention rates are high, no matter what these are placed for, outside of the nival lesions, there is increased patency and improved symptom relief with associated stenting. And really, in my opinion, IVUS should be used in all of these to evaluate the iliac vein for sizing, determine if there's associated compression before you place a stent. Again, I'd like to thank the New Horizons webinar committee, the MVSS, and Drs. Bachar and Dr. Lin for letting me speak this evening.
Oh, that was an extensive review on the venous stenting for ilofemoral DVT. So moving on, our next speaker is Dr. Nader Tahari, who is a vascular surgery attending at Northwest Community Healthcare, and he's originally from Michigan. Dr. Tahari is a community-based vascular surgeon out of Arlington, Illinois. He completed his general surgery residency at Southern Illinois University in Springfield and went on to fellowship at Loyola University in Maywood. His current practice is broad-based vascular surgery with an emphasis on venous and cerebrovascular disease. And he's very grateful for all the wise tutelage that he has received and continue to receive from Dr. Bachara. Dr. Tahari will present an IVC filter placement and retrieval tips and tricks. Take it away.
Thanks a lot for the opportunity to speak. It's good to see you, Drs. Bachar and Solt. I trained under both of them. I have no disclosures. In terms of the outline of my talk, I'm going to talk a little bit about the background just because I like to look at the history and see where the technology came from. I'll talk a little bit about the indications for placement because I think this is really the crux of IVC filters, knowing when is appropriate to place them. Some considerations in terms of anatomics, variability, and things to consider when you're placing them. Then moving on to filter removal, standard removal, some advanced endovascular techniques, and then briefly just touch on open surgery. So in terms of background, vena cava interruption has been performed as early as 1700s to 1800s via open technique. The thought and development towards this procedure and technique really has been the idea that we're trapping emboli while maintaining adequate blood flow. Understandably, a lot of the earlier efforts failed, resulting in venous thrombosis. The first umbrella design filter was placed in 1967. It was placed transvenously with the new onset of transvascular techniques. The Greenfield filter, the original stainless steel Greenfield filter, came out in 1973. More recent developments have really been focused on retrievable filters and removing them with the new data that's been out. In terms of indications for placement, there are a lot of indications, and you can really break it down into the evidence-based guidelines and then the expanded indications. Looking at the evidence-based guidelines, the strongest data supports the documented venous thromboembolism and patients who have a contraindication to anticoagulation or have had a complication of anticoagulation, patients who have had pulmonary embolism despite therapeutic anticoagulation, and venous thromboembolism with the inability to achieve therapeutic anticoagulation. The expanded indications, there's a huge list of them. I really kind of broke it down into patients, poor compliance with anticoagulation, venous thromboembolism with limited reserve, patients who already have underlying cardiopulmonary disease, and then venous thromboembolism in high-risk patients. These are the trauma patients, cancer patients, and post-op patients. Understanding that these expanded indications have less data supporting it. In terms of breaking it down, the way I like to think about it, when you look at these long lists of expanded indications, for me, the strongest data supports the presence of a DVT or PE and either a contraindication to anticoagulation, complication, or failure of anticoagulation. And this is supported really by the chest physician guidelines in 2016, as well as the Society of Interventional Radiology guidelines in 2020, which was also done with the support of the Society for Vascular Surgery. Taking this all away, what I like to remember is that if a patient has a venous thromboembolism or is at risk, but they can tolerate anticoagulation, there really isn't a very strong indication for filter placement. In addition, it should not be primary prophylaxis in patients without venous thromboembolism. Obviously, this is different in the real world. You know, a lot of surgeons ask for IVC filter placements for various procedures, wanting to keep them off anticoagulation. All I can say is you have to have a close discussion with the operating team and have a timeline for removal of these filters when you do place them. In terms of placement considerations, looking at the anatomy of the IVC, break it down to 4 segments: infrarenal, renal, suprarenal, and hepatic. Some landmarks to remember: the origin of the IVC around the L4, L5 level. Renal veins come off around L1, L2, with the right renal vein usually being a little bit lower. There are some anatomic variations to be aware of: renal vein anomalies, circumaortic or multiple renal veins, understanding that not only generally you want to land the filter below it, but in situations where you have multiple renal veins entering very close, this can lead to a big ostium, which you may inadvertently land a leg into and could result in tilt if you're not aware. IVC transposition and duplication, very rare, but once again, this changes where you're going to put the filter, either place it suprarenal or place one into each duplicated infrarenal segment. And then IVC agenesis, which is also very rare and generally is thought to be a contraindication for filter placement. However, placement in very dilated azygous veins has been described. Some placement tricks, a lot of these patients come with imaging ahead of time. It's important to review this, any CTs, duplexes to identify anatomic variants. I routinely get a lower extremity duplex to assess for axis site thrombosis. During the procedure, I perform an intraoperative venogram to look for IVC thrombus. I then perform a measurement of the IVC through the venogram. Most of the filters generally have a maximum diameter around 28 to 32 millimeters. The Cook Select dilator that comes with the filter actually has 2 markers on it that are 30 millimeters apart, so you can use it to gauge the diameter of the vena cava. And then you can also use a marker catheter to measure it. In terms of during the procedure, after that, I use the venogram to identify the renal and common iliac veins. This is either done through venography. Sometimes it's not very easy to see. So you can either use bony landmarks and correlate it to preoperative imaging, or you can use IVUS. In terms of landing it, the tip of the filter usually lies below the renal vein, which is on the right. Suprarenal placement can be done if there's extensive thrombus or there's an anatomic variation. I'm not going to talk about this too much. You can perform transabdominal ultrasound guidance for patients who can't come down to the cath lab, patients who are too sick. You can use the ultrasound to get your landmarkers and deploy the filter. Generally, you want at least before you bring all your supplies up, get a pre-procedural ultrasound just to make sure you can actually see what you need to see. And then finally, IVUS guidance to place this. This can be done at the bedside with the portable imaging tower. If you have it, it's nice. You can measure the IVC diameter. And then if you're having difficulty visualizing the confluence of the iliac veins, you can place a good trick is a contralateral wire on the other side, and seeing where it passes across, you can identify the confluence of the iliac veins. Generally, I use the IVUS in a pullback technique to kind of get my landmarks and get my bearings, starting at the right atrium, pulling down to identify the hepatic veins, the renal veins, and then getting a measurement of the infrarenal IVC. So filter removal really begins at the time of placement. When you're putting these, you should have an idea of when you're going to take it out and stick to that plan. You should remove them when the risk of pulmonary embolism is low and when anticoagulation can safely be resumed. When these patients show up in clinic or when you're consult and there's no imaging, you have no idea what type it was or when it was placed, I do obtain preoperative imaging just to show me what type it is, because sometimes you'll be surprised and that can definitely change the approach. In terms of technique, for a standard removal, I generally come from the jugular access. I take a pre-removal essential venogram to ensure there's no IVC thrombus. Then using the standard snare, I get across the hook and then sheath it. Fairly straightforward. In terms of some advanced techniques, Generally, if I'm expecting it to be a complex retrieval, if it's been in for a long time, or if there's a significant amount of tilt, I will start with a large sheath, 14 or 16 French sheath, just so I have some options. In terms of my workflow, generally I start with telescoping. I'll then move on to loop snare, endobronchial forceps, and then finally a few different fibrin disruption techniques. And that's just kind of how I escalate these in my mind. Starting off with the loop snare or the hangman technique, I'll pass a omniflush or a curved catheter past the filter, then get an 035 glide wire and then snare it. Once again, having a large sheath helps with this. I'll then pull up on the wire and make sure it's seated underneath the body of the filter. This is very important. This picture on the right is not what you're shooting for. You do not want it just underneath one or two of the tines. This can lead to further tilt and can even fracture the filter. Next, I move on to endobronchial forceps. You can do a little bit of dissection with it. Once again, taking care to grab the main body of the filter and try to pull it into the sheath. And then there are various fibrin disruption techniques. I usually resort to the balloon. If you get a wire down and inflate a balloon, this can disrupt some of the fibrin and sometimes can reduce the tilt and straighten your filter, make it easier to retrieve. There is a double snare technique. I haven't personally done this, but basically you come from above and below and try to loop it. You can loop it from below. That can help collapse it and also straighten it, facilitating snaring the hook from above and pulling it from above. In terms of finally, fibrin disruption techniques, you can use a laser sheet that they use for lead extraction. I don't have any, I've never done this before, but for filters that are really embedded, once you get into sheath, you can use it to essentially cut the fibrin sheath and retrieve the filter. So just a couple of videos. This was actually an Optese. You can see on the right, this is a good view of me using everything basically. I actually did this with Dr. Bashara as a fellow, using endobronchial forceps and a balloon to disrupt the fibrin and then pulling it. And then on the left, I'm using the telescope technique, basically with the large sheath trying to pass a smaller sheath within to try to disrupt the fibrin and pull it and pull the filter into the larger sheath. One thing I just want to mention, just kind of a unique case. I've done a couple of these as an attending. Generally, thrombose filters were left in place. But one thing that to consider if a patient has thrombosed the filter, has extensive DVT, iliofemoral DVT, and is symptomatic, you can retrieve these using a new Protrieve sheath out of Inari for protection for PE. This is a case I did fairly recently. Patient had extensive IVC and iliac vein thrombosis with extensive scrotal and bilateral leg swelling. I was able to basically deploy the Protrieve sheath. You can see the protection cone up above, use the FlowTriever to kind of debulk around the tip of the filter and then ultimately retrieve it. Finally, just a couple points about open removal. Generally, this is reserved if endovascular techniques are unsuccessful and the patient is symptomatic. It's very important to weigh the risks of just leaving in the filter versus open surgery, as this is a rather large operation. Exposure to IVC, I won't go too much in detail, but it's a right medial visceral rotation, Cochran maneuver to facilitate more exposure. Just some things to keep in mind. Watch out for the lumbar veins. If you can ligate the ones where you know that you'll be doing your venotomy, that can definitely help. The hooks, once you have proximal distal control and you've opened up the vein, the hooks can still be challenging. You think it's open surgery, it'll just come out, but they can be very difficult to get out. You have to kind of unhook them, and sometimes you have to kind of take them apart piece by piece, have pliers and wire cutters ready. Thank you.
All right, that was a nice talk, Dr. Tarani. Thank you. So last but not least, we have Dr. Jody Gerdes. She's a vascular surgeon at Alina Health Minneapolis Heart Institute in St. Paul, Minneapolis. She completed her fellowship training at LSU, and then she was an assistant professor of clinical surgery at LSU in New Orleans. Then she moved on private practice in Tennessee, and then now she's back now she's at her current position with Alina Health. Dr. Gerdes will present best medical management after venous stenting.
Good evening, everyone. Thanks for the opportunity to speak tonight. I'm going to be talking about medical management after venous stenting. I think best should probably be put in parentheses for this talk, but we'll do our best. I have no disclosures for this talk. So why is this topic important? Well, coming next month in the Journal of Vascular Surgery, there's an abstract that will be published regarding the usage trends of venous stents in the United States over a 7-year period of time. So without getting into too many details about the abstract, basically in 2019, the FDA approved 2 venous stents, and a couple of years later recalled both of those stents. So this abstract and this data in this abstract is looking kind of through this period of time and the usage of venous stents over, again, the 7-year period. So if you look at the kind of overall numbers through this period, it appears at first glance that venous stent usage is going down, but if you look at stents used per day, it's actually significantly increasing. So it's an important topic. As mentioned previously, these can be challenging cases and can have complications such as in-stent restenosis or stent thrombosis after the procedure. And obviously our number one goal is to provide long-term symptom relief for our patients. So where are we at currently? In 2022, the European Society for Vascular Surgery published their guidelines regarding chronic venous disease. And I highlighted in red at the bottom that they stated that post-procedural anticoagulation and antiplatelet treatment after iliac vein stenting remains a matter of debate. So we're going to kind of walk through that debate tonight. Current practice following venous stenting as far as anticoagulation and antiplatelet can include any one of these regimens. And obviously I made this slide dramatic for a reason. So it leaves a lot of unanswered questions regarding medical management, whether or not the patient should be anticoagulated, how long they should be anticoagulated, which is the best medication, and is there a role for antiplatelet therapy? So here's kind of an overview of the talk tonight. We're going to start with a review article and then go through an article with these different patient populations to try to figure out if there is best medical management following venous stenting in each different cohort of patients. So the review article is from Northwestern University, published in 2020. This is from the Department of Radiology, titled Antithrombotic Therapy After Venous Stent Placement. So they noted that our current practice regarding medical management after venous stenting is largely based off of our experience with arterial stents, and that may not be correct. They also noted in their review that there's a large variation in study designs, outcomes, data, and the time period after which these patients are followed. So here's the studies that were in their review. Again, just kind of looking at this chart briefly, you'll see that there's surveys, there's larger meta-analyses, there's retrospective reviews, there's case series. Again, the patient populations are varied. And kind of looking over at this conclusions column, you'll see a lot of variations in recommendations, different medications that are used, different time periods. So they attempted to come up with some conclusions based on their review. So they concluded that postoperative anticoagulation following venous stenting is likely needed, but the time frame over which these patients are anticoagulated remains a matter of debate. They suggested that 3 to 12 months, which is still a large range, might be sufficient unless there's additional risk factors in these patients or other indications for anticoagulation. These authors concluded that DOACs may be the preferred agent. The addition of antiplatelet therapy may reduce in-stent stenosis. The etiology of the disease can play a role in your postoperative management, and thrombophilia in the setting of venous stenting is not well studied. So at the end of their review, they did suggest this particular algorithm for anticoagulation following venous stenting. They kind of broke the patients down into those with thrombotic etiology versus non-thrombotic etiology. They again preferred DOACs for a period of 6 to 12 months with an antiplatelet agent. And then following that 6 to 12 months, continuing with an antiplatelet agent indefinitely, or if there were other risk factors or a history of multiple DVTs, they suggested consulting hematology and considering lifelong anticoagulation along with an antiplatelet agent. So moving on to our first cohort of patients, those with non-thrombotic venous lesions or NIVLs. This is an article published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders from May of last year, looking at immediate post-procedure anticoagulation with factor Xa inhibitors. And they specifically looked at stent patency. So this is a retrospective review covering a 2-year period of time, looking at iliac vein stents placed for symptomatic non-thrombotic iliac vein lesions. So in practice, a patient with May-Thurner who's symptomatic but has not had a history of DVT related to the May-Thurner anatomy. They broke their patients down into 2 groups, those that received anticoagulation with either rivaroxaban or apixaban for a minimum of 90 days. That was then continued at the discretion of the physician, particularly in those patients if thrombus was noted within the stent or at the insertion site. The second group were those patients that did not receive any postoperative anticoagulation. Their primary outcome was stent patency, which was analyzed by ultrasound at these time intervals. So antiplatelet therapy could be continued in these patients if they were on it preoperatively, or if it was added postoperatively, then those patients were included in the non-anticoagulation group. So they found that for primary patency, which is again their primary outcome, they did not note a difference in primary patency between those patients that were anticoagulated versus those that were not anticoagulated. So their conclusions were that patients with non-thrombotic iliac vein lesions should not routinely receive anticoagulation following venous stent placement. Anticoagulation could be started for those patients that demonstrated on their follow-up ultrasounds thrombosis at the insertion site or layering within the stent itself. Pregnant women should receive low molecular weight heparin if they have iliac stents, and any patient with a hypercoagulable disorder should be anticoagulated as well. So moving on to the next group, those with an acute iliofemoral DVT. This is an article published in the JVS in September of last year, looking at risk factors and classification of re-intervention following these stents. So also a retrospective review covering a 4-year period of time, including patients that had symptomatic acute or subacute iliofemoral DVTs for less than 28 days duration. These patients underwent thrombolysis followed by iliac vein stenting. They were followed for a minimum of 12 months, and re-interventions were performed on these patients if they had a greater than 50% stenosis within the stent, if they felt that the stent was threatened, if there was a correctable anatomic issue, a stent occlusion, or a mechanical problem such as stent fracture or compression. Their regimen for medication management following the procedure was to start the patient on a therapeutic low molecular weight heparin within an hour of the procedure. This was then continued for at least 2 weeks, after which the patient was surveyed with ultrasound and then transitioned to an oral anticoagulant. So again, one of the aims of this study was to develop a classification system regarding reintervention. So they kind of broke it down into 4 categories, one being hematologic. And they found that a lot of the patients requiring reintervention had a dose-related hematologic issue, and that was usually non-compliance with this regimen of Lovenox, then transitioning to an oral anticoagulant. So non-compliance with the anticoagulation regimen was found to be statistically significant and leading to more reinterventions in these patients. So again, hematologic issues were identified in 1/3 of these patients that needed reintervention, and the vast majority of those were dose-related and the vast majority of those were non-compliance with the regimen. So they suggested a multidisciplinary approach to post-procedure anticoagulation, again, using hematology if needed, considering any underlying thrombophilia, and when the patients were transitioned to an oral agent, consider a DOAC, just for ease of use and compliance. And finally, the last group of patients are the most complex, those that have undergone iliac stenting for venous outflow occlusion. This study looked at early thrombosis regarding the disease severity and type of anticoagulation that was used. This was also published in the JBS in 2021. Also, a retrospective review covering a 10-year period of time, looking at patients that underwent venous stenting for chronic obstruction. This could have been in the common femoral distribution, the iliac veins, or the IVC. Their primary outcome was stent thrombosis or reocclusion within 3 months of implantation. So this study was interesting. It was 2 hospitals and 11 different interventionalists. Their post-procedure regimen varied. About half of the patients received antiplatelets following the procedure. Greater than 95% were anticoagulated, and the vast majority of those were anticoagulated with a low molecular weight heparin. That was either used as a bridge to warfarin or continued for 2 to 4 weeks before transitioning to an oral agent. About 37% of these patients were started on factor Xa inhibitor, and a smaller percentage were just continued on warfarin, and those patients were on a long-term warfarin regimen, and that was not held for the procedure itself. So they identified several factors related to early stent thrombosis that reached statistical significance. I've started the important ones regarding this talk, but the presence of a hypercoagulable state led to more stent thrombosis. The type of anticoagulation, and specifically utilizing low molecular weight heparin for greater than 10 days following the procedure, led to fewer stent thromboses. So here's a graph comparing the 3 agents, either factor Xa inhibitor, low molecular weight heparin used for greater than 10 days, or warfarin, looking at the primary patency rates over the 2 years following stent placement. And the orange line is the low molecular weight heparin, which performed better. So their discussion in this article was quite interesting. They postulated why low molecular weight heparin may be better than factor Xa inhibitors, and they suggested that the factor Xa inhibitors had a more limited effect on the coagulation pathway, and the anti-inflammatory effects of low molecular weight heparin is beneficial. So why was low molecular weight heparin used for greater than 10 days beneficial? They felt that this was a more consistent anticoagulant effect versus transitioning earlier to an oral anticoagulant. Obviously, this can be a difficult regimen for patients to comply with, so it's something that you need to discuss with your patients preoperatively, and they have to be willing to participate in this regimen. They really felt that that initial period following recanalization of a chronically occluded lesion, followed by stenting, when that stent is exposed and the new intima is forming, may require a more intense regimen of anticoagulation versus a long-term regimen. So at the end of their review, they did recommend low molecular weight heparin at therapeutic doses for 3 to 4 weeks before transitioning to an oral anticoagulant. So to go back to the overview, to kind of just recap all the data we just talked about, the review article from Northwestern Radiology suggested utilizing a DOAC with an antiplatelet for at least 6 months and then transitioning to an antiplatelet indefinitely. For the patients with a non-thrombotic iliac vein lesion, anticoagulation prophylaxis is not recommended. For those patients with an acute iliofemoral DVT, utilizing low molecular weight heparin for at least a 2-week period before transitioning to oral anticoagulation is recommended. And then finally, the most complex patients with venous outflow obstruction, the recommendation would be to utilize a low molecular weight heparin at therapeutic doses for 3 to 4 weeks before transitioning to an oral anticoagulant. So again, I don't know that I can demonstrate or define for you the best medical management, but I think this slide kind of sums up as the patients become more complex, perhaps using a low molecular weight heparin initially and then transitioning to an oral anticoagulant seems to be the trend in the literature. So did we answer any of our questions? Maybe regarding anticoagulation or not? I think, again, that overview slide kind of lays it out. How long to anticoagulate these patients is a question that needs to be studied further. Which anticoagulation to use? Again, that low molecular weight heparin seems to be important in that early period, but the oral anticoagulation used after that is debatable. And is there a role for antiplatelet therapy? In next month's JVS, venous and lymphatic disorders, this abstract will be published regarding the use of early antiplatelet therapy following deep venous stenting and interventions. So for the sake of time, we won't go into a lot of these details, but this is, again, a retrospective review. They kind of grouped the patients together, looking at patients with less complex disease and those post-thrombotic more complex patients. Their primary outcome was 1 year primary patency. Their regimens were somewhat varied as well, but their overall primary patency was at 90%, which is pretty phenomenal. They found that at 1 year, primary patency was improved in those patients that had received antiplatelet therapy. But it suggested that that antiplatelet effect may not really go beyond 1 month. So they concluded that antiplatelet therapy at discharge protected against the need for reintervening on these stents. Surprisingly, obviously this is just an abstract, but it did mention smoking status, which is, other than showing up in a table of patient variables, this was the first reference I really found to smoking status, which I thought was interesting and also a variable that needs to be studied. So there is hope for maybe more definitive recommendations. These are 2 studies that are ongoing currently and set to be completed in the next 1 to 2 years. And obviously, as new venous devices hit the market, more investigation will be needed. And with that, I'll say thank you again to the society and the moderators for having me this evening.
That was fantastic. Thank you, Dr. Gerdes. I actually recently was doing a course with Dr. Desai, and he mentioned the low molecular weight. So I'm glad you brought it up, because I think I'm going to start doing that in my practice. I honestly haven't, despite the literature, I haven't been doing it myself, but it makes sense. But real quick, Dr. Gerdes, if someone comes in with a occluded stent and they've been on NOAC, do you automatically switch them? Let's say they're on Eliquis. Do you switch them to something else, or do you think they're non-compliant? I mean, how do you evaluate non-compliance in some of these cases? I'm just interested in your thoughts on this.
Yeah, I think a really good history from the patient, and sometimes you need the family to help you with that, to kind of fill in the details. If you want to get really tricky, you can call the pharmacy to see if they've actually filled their prescription, to really try to nail down if this is a failure of their medication or not. Yeah.
So I think I answered Dr. Arbit's question about, I know the insurance asks for 5.5. I must add that article I sent, it's an old article, I think published in either early 2000s, early 19 something. But, and also Dr. Mark was talking about a size stent. I think maybe he's referring to a paper from Mississippi that I think they usually use 12 to 14, if I remember well, stents, or nothing under 10. But I think what he's trying to emphasize the importance of sizing, because you don't want these stents to embolize, and that's why Dr. Solwell mentioning the size with IVUS, which is, I think, is crucial. But I'm going to ask Dr. Short and everyone else, do you have problem taking the stent across the profunda down the common femoral vein? What's your technique for that, or should we be doing more endo phlebectomies and patches?
Yeah, I mean, that's a great question. I mean, I really try not to cross the inguinal ligament if at all possible. I mean, obviously it's all, especially in acute DVT, it's all about inflow. And so I think that's where the multitude of devices that we have now to really improve that inflow, whether that's mechanical, pharmamechanical, Even if you need to sort of leave a lytic catheter behind to get that inflow. If you don't have inflow from the leg, it's not going to work. And really, the literature is pretty clear that, and even the, our guidelines say don't put peripheral stents. So as soon as you kind of cross the ligament, that's when stent fractures, higher rates of stenosis, higher rates of occlusion all occur. So I think really trying to land short of that, if at all possible, is kind of the goal. But I agree. I mean, going longer, like I said, in my response, it's, longer lengths are better. You need to anchor it. We don't want to have these things embolized, because that's going to be a major, major problem if we do. And we don't want to end up, like I said, we don't want to be down the IVC route of everybody getting sued for putting an IVC filter in.
Yeah, I agree with the type of stent does matter. I think, in my opinion, the ones that I've had fracture with the Venovo stents, and the wall stents and the Opry stents, I have crossed inguinal ligaments without problem. So, and I usually just, if they do fracture, I just basically go in and reinforce it with another stent. So that has not been an issue. But I'm more about migration too, because now I'm starting to put stents for nutcrackers, the left renal vein compression. In select patients, I think it works. But on the other hand, I'm very, very cautious that it's going to embolize. So you really have to size it properly, and go big and go long is usually my model for these. Yeah.
I'm trying to be mindful of the time, but a few more, maybe two more questions. Okay, Dr. Chen. So what's your approach for recurrent varicose vein? Are you high ligation? Do you do high ligation, or do you go after another endovenous attempt?
Yeah, that's a great question. I personally try to avoid the high ligation and stripping if I can. I think the current guidelines kind of suggest that as well, which is that the morbidity and pain associated with it kind of outweighs the benefit there. So I usually try to rescan and see if there's another truncal vein that's refluxing and now contributing to the recurrence that wasn't appreciated before. And so with that type of recurrence picture, I try to go after that truncal vein. I do want to also add to the question that was asked earlier about the insurance-based sizing cutoff that they have. There's a great paper from JVS back in 2012, so not new by any mark, but it was discussing, it's by Dr. Kathleen Gibson and colleagues, looking at great saphenous vein diameter and correlating with quality of life scores. And I really enjoy the way that they've concluded it. They say great saphenous vein diameter is a poor surrogate marker for assessing the effect of varicose veins on patient quality of life. Thus, using great saphenous vein diameter as a sole criterion for determining medical necessity for the treatment of GSV reflux is inappropriate. And I think that's something that whenever we're on a peer-to-peer is always helpful to have written in the literature and stated so clearly.
Well, if you can also, I guess, send the link, we can circulate to the participants too.
Surely.
Dr. Turani, does the years filter in dwelling time, I should say, of the filter, does that make you go straight to a bigger sheath, or would you try it first with a retrievable kit, or do you have an algorithm when to go straight to a big sheath or not?
Yeah, I think for the dwell time is important. The tilt, I think less so. If it looks straight, even if it's been in there for a while, I'll try with the standard sheath. If it's tilting, then tilting and it's been there for a long time, or just tilting, that's when I'll go with the larger sheath.
Okay.
And that the filter does matter, like Cook Select. I mean, those can come out like after 5 years, they come out very easily. But the Gunter Tulip, they tend to become very inflamed and adherent. And it was very hard to, they just attach the wall with a 5-inch sheath. So it's very hard. Yeah, usually after a year, I would probably put the 16 French sheath because it gives me more option than just to use the 10 French Cook retrieval device for the one that are within a year or so.
Well,
Yeah.
Doctor, I'm going to ask you actually a question, because I know you do robotic removal. So if the struts are sticking outside, do you actually cut them ahead of time and then open the cave and remove them?
No, not for the robotic. We didn't actually did it for the open. I had to do that for the open because we couldn't retrieve it endovascular. We always try endo first, of course. I think at more than 95% of the time we can get it open. We could do it endovascularly when they're really, really hard. And yeah, I know then it's questions like why do you want to do it? Well, this one was going into the duodenum, and every time she was eating steak, it would get stuck in a 33-year-old. It's a miserable life to be in. So, and I couldn't do it I couldn't do it. So I did it open, I cut the struts out and then retrieved it that way. But the robotic one was actually very more straightforward. What we had to do is we basically had to the hooks on it was sticking outside, and you have to sort of strain that hook before you can actually pull it out. So, because you don't want to rip the vena cava. So that's the other trick, because we didn't have the plier. So we just had to straighten out the hook, the struts before removing from the IVC. Little tips and tricks, I guess.
Well, this was a fantastic session, and it was great to hear all the speakers and moderate with you, Dr. Lin. So, and we want to thank Cook Medical for the sponsorship. Any other announcements, Dr. Lin?
Well, yeah, it looks like it's coming to an end tonight, and I want to thank everyone and for participating, as well as helping us promote venous health. As we know, that March is Stephen T. Awareness Month, and it's a public health initiative aimed at raising awareness of this commonly occurring medical condition and its potentially fatal complications such as pulmonary embolus. So during the last hour, we learned about these new and exciting innovations for managing these complex venous disease from these experts, vascular surgeons, and that could affect your current and future practice. So I hope I certainly learned a lot tonight. So I enjoyed chatting with all you. And with that, have a good evening, everyone, and take care. Good night.
Thank you. Bye. Thank you.
Thanks.